Head-to-toe examination, there was no cephal hematoma, no concealed bleeding, anterior fontanelle open and flat, face, no dysmorphic features were seen, eyes deep yellow in color, sclera was deep yellow in color, ears well formed, no low set ears, skin orange yellow in color up to soles. Genitals were normal. Systemic examination.
Before examination, after history, some provisional diagnosis. What do you think? Nirmala madam?
Prolonged jaundice, sir, usually. So,
Yes, sir. Yes.
Okay. Before head to examination.
So it was prolonged jaundice, sir.
No, you put previous slide. Okay. 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 At the end of history, after history, before going to general examination, what are the possibilities in? Usually after history, we should always diagnose provisional diagnosis. As Dr. Surendra was telling you, try to diagnose the system first of all. Even if possible, in the system, which organ is involved. This is the idea of keeping the provisional diagnosis. Why you should do provisional diagnosis before going to examination? To know which system of the system should be examined. Otherwise, it's very difficult to examine which system. So now provisional diagnosis, what do you think?
According to the history, it was prolonged jaundice, sir.
Okay. First of all, what type of jaundice you think in this? Clinically, suppose it is, think of what type of jaundice. No examination, no laboratory diagnosis. Only history we are in the history. We are in the story.
Here you said urine and stool are normal. So
color.
what clues can you get from this history? Urine and stool, what are the clues you can get? That's what
color of the urine and stool says.
Unconjugated hyperbilirubinemia, sir.
So
you are trying to rule out conjugated. Conjugated, you are trying to rule out.
How you rule out conjugated? How do you?
Sir, stool color was normal, sir.
Supposing if it is yellowish, yellow urine and
high-colored urine, pale stools suggestive of conjugated hyperbilirubinemia. It may be sepsis or any
obstruction. Indicates obstruction, intrahepatic or extrahepatic obstruction. Obstruction when bilirubin is not coming into the intestine, so stools are always pale. And conjugated bilirubin being the water soluble, so you will get always high-colored urine. So that should be your clinical and history diagnosis to know difference between unconjugated and conjugated. Okay, when now you are thinking unconjugated, what are the possibilities you think in the unconjugated jaundice and history?
So what was the onset? What was the day of onset? Based on age of onset, how will you differentiate? Is it not?
Correct, madam. Yes, that's what I'm asking. The day one, you start with day one. What do you think?
Day one, it's a absolutely pathological jaundice, sir.
And history, what do you think? Family history, what do you think?
Usually, mother's blood group will be Rh negative, sir. Rh negative, and there may be any ABO incompatibility.
How?
Mother may be O positive, and baby may be A or B positive, sir.
Maybe no. You say mother is O. Mother spelling MO. So mother is always O. Baby spelling BA. So baby can be B or A or AB. But Rh incompatibility, we are not completely told. Mother is Rh negative. What husband also negative? Do you get Rh incompatibility?
If father is heterogeneous negative, sir, then there is a chance of 25% of getting positive, sir.
So classically, you say that when mother is negative, Rh negative, father is Rh positive, and baby is Rh negative. Can you get?
No, sir.
No. What I'm trying to tell you, you should be very clear when you're whatever you are speaking. First day, Rh incompatibility, mother is negative, father is positive, child is negative. ABO incompatibility, mother spelling mother O, mother is always O, baby is AB or AB. Why? When both are happening, Rh incompatibility and ABO incompatibility, the jaundice will be doubled, single or off?
It will be less, sir. Less.
Very good. Why it is less? Yes, you are right. Absolutely very good. Why? Which prevents which one?
ABO incompatibility will neutralizes the Rh Rh immunization, sir.
Good. Okay, coming to the proceed with examination. Okay.
Yes, sir.
Anything, madam? Nirmala.
Yeah. So the age of onset is if you said pathological jaundice, if it is in the first day. Similarly, what differentials would you like to think about? I mean, what are the possibilities? Age of a baby started developing jaundice on 26th day of life. Is it not?
Yes.
So you have ruled out based on the blood group of the mother you had told us. So you would like to think about any hemolytic process, or you would like to think about, based on the activity of the baby, you would like to think about any sepsis, is it not? Yes. But here, when it is a late onset, presenting in the fourth week.
Fourth week.
So can you think about
usually hypothyroidism and breast milk jaundice, breastfeeding jaundice, and any hemolytic jaundice, any syndromes, ma'am. Downs, baby looking good and there is no syndromic phases. Even we can think of,
that is, I would like to know whether the child had any physiological jaundice or not. The point I want is, when does it start and when does it disappear?
Disappears, yes.
Usually physiological jaundice starts around 3 to 5 days, ma'am. And it in term babies it ends around 2 weeks, 10 to 40 days. Thus in preterms it ends at 3 weeks, ma'am.
So by 7 to 10 days it goes off in term babies. In preterms it may go up to 2 weeks, correct?
Yes, ma'am.
So if there is any prolonged physiological jaundice, what will you think of?
Prolonged physiological jaundice, it may be breastfeeding jaundice, ma'am. And physiological jaundice may be aggravated by and prolonged by hypothyroidism.
Okay. Anything else? So do you think like this, madam? So prolonged physiological jaundice after 2 weeks, always think of 1 dozen hypos. Hypothyroidism, glucose, hypothermia, hypo pH, that means acidosis, immunity, infections, like that. You remember the way of remembering all hypos, any name hypo can cause, as madam is asking, prolonged physiological jaundice. So you are telling about the breast milk jaundice and breastfeeding jaundice. Are both are same or different clinically? How you differentiate? Any possibility?
So breast milk jaundice, breastfeeding jaundice, sir. Breastfeeding jaundice is the deprivation of feeding, sir.
Yes. Good.
Due to the deprivation, there will be sterile gut and activation of enzyme, that is beta glucuronidase,
which increase enterohepatic circulation. Good.
Increase the circulation, sir. Whereas breast milk jaundice due to the
defect in the milk, mother's milk,
sir.
Again, usually, same thing, hypo feeding, hyponutrition, hypo milk, all will prolong the physiological jaundice. Okay.
We know, try to explain difference when the onset of jaundice, how it progresses, when it attains peak in both breast milk and breastfeeding jaundice.
That is again one more is.
Usually in breast milk breastfeeding jaundice, sir, usually it appears around 1 week, and it usually disappears by 2 to 3 weeks, sir. Whereas in breast milk jaundice, it usually appears around 2 weeks. And
1 minute. There is one issue in this case, Vinod, whether the jaundice really started on 26th day or the jaundice was there in first week, maybe there was a low and then it has started again, something like biphasic. This is the first thing you have to ascertain in the history. Then you frame a diagnosis. I'll repeat this. Is it really jaundice whose onset is on 26th day? Your diagnosis would be totally different. And is it a jaundice which was there in the first week also? Maybe in the second week it was somewhat down and then it is more. This you have to ascertain from history itself. Restart, revisit the history and then go for a diagnosis. This is my advice.
So in past history, sir, as discharge, baby's TVs was 10.8 milligram per deciliter, sir, which was around 14 milligram per deciliter at third day of birth, sir.
Again,
Simple. How do we assess clinically? What is Kramer's criteria rather?
Kramer's criteria, it's a we assess the amount of jaundice by seeing the discoloration by skin, ma'am. Clinical
From
clinical
head to
criteria
toe. Is it?
up to head and neck, it's 6 to 8 milligram per deciliter. Whereas up to umbilicus, it's 4 to 6
Okay.
4 to 6 head and neck.
Okay. It's basically
Kramer says about severity. You guess it. Here the question is duration. When was the onset? If the onset is in first week, this is a 3 weeks, 4 weeks jaundice. If the onset is on 26th day, the jaundice first appeared on the 4th week. First ascertain whether this jaundice had started on 4th week or it was there in the first week itself. You have to ascertain this by history alone, then you can frame diagnosis.
But in this history, it started on 3rd day.
So, actually, child was in Hyderabad, sir, when he born. In Hyderabad, they were admitted for admitted on 3rd day of life, sir.
And for jaundice only, first day, 3rd day, there was jaundice, they noticed.
So 3rd day they noticed jaundice.
This is a second, Vinod. This is a second admission this is a second hospital.
Yes, sir.
This is admission, this is second hospital and second admission.
Yes,
then
sir.
You cannot present it as 26th day. Jaundice appeared on 26th day. It is a continuous process, no? The jaundice is something which appeared on 3rd day, has continued over this time, and the child is in a second hospital. In the second hospital, the jaundice did not start. It started in the patient at home or in the nursing home. Then the baby is in 2 hospitals. So so you would say the jaundice which has started on 3rd day.
Yes.
It is not even biphasic. It is not even biphasic.
It is continuous.
Yes. Carry on.
Actually, they went for review, sir, after 4 days. It is on 10th day of life in Hyderabad, and TSB was taken, which was around 10 to 11, sir. 10.6 milligram per deciliter, sir.
Okay, let us not mix again labs. Jaundice appearing on 26th day, that confuses us. Jaundice appeared on 3rd day. Multiple times the investigations are done, that is there with you, that you will present while you are giving your past history and investigations.
The point which Sir was trying to convey is the age of onset. I am coming back to the same point again. Age of onset, and from there it is
prolonging. How prolonging?
Prolong.
How it is prolonging?
In the differentials, whether we take it as a prolonged jaundice, where your DDs will be different.
Yeah.
Okay, that's what. The point to be noted is that. Okay, proceed.
On systemic examination, baby is conscious, active. CVS was S1, S2 present, no murmur. Respiratory system, breath sounds normal, no adventitious were present. For abdomen soft, no hepatosplenomegaly. On CNS examination, pupils were bilateral, normal size and reacting light. Tone normal in 4 limbs. Deep tendon reflexes present. Plantar reflexes were present. Provisional diagnosis: 29 days old male child born out of LSCS at 38 weeks of gestation with complaining of yellowish discoloration of skin and sclera. For provisional diagnosis, prolonged jaundice. These were my differential diagnosis, ma'am. More than 14 days and prolonged jaundice.
Sriram Reddy, sir. Unmute, sir. Unmute, sir. Mute lo unnaru. Unmute cheyandi.
No, just I was telling that don't depend on the lab findings and insist on that 10, it was 10 milligrams like that. You have to see the physical examination and then you can say it, because lab, it differs from lab to lab. So that is not the very significant importance to find out. Another important thing is, okay, go ahead. Go ahead.
My
differential, okay.
A differential diagnosis were hypothyroidism, sir. Hypothyroidism, breastfeeding associated jaundice, breast milk jaundice, infections, or occult or overt internal bleedings, red cell enzyme deficiencies, ABO incompatibilities, RH incompatibility, Lucey-Driscoll syndrome, Gilbert syndrome, Crigler-Najjar syndrome type 1, or Crigler-Najjar syndrome type 2.
So like that, I already told you, remember this differential, all hypos, hypo enzymes, hypo feeding, hypo food, hypo alcohol, everything, the hypo pH, like that is easy way of remembering. Okay, proceed.
So, manager, on day 1 of admission, isolate P was started at 13.7 ml per hour. And
Now, ultimately, what you are diagnosed here?
uh,
You had only told the differential diagnosis. Ultimately, what is the diagnosis?
ఇంకా ముందుకుంది సార్
ఇంకా ముందుకుందా? Okay, proceed. Okay.
Investigation, sir. Investigation.
Okay.
No, before investigation.
Vinod.
Provisional.
Then truncate the DD. Now, which DD you want to take out?
Take out.
Type 1, type 2, they are very different. No? They present very, very differently. So of these 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. In 12 DD, which one you want to remove right now?
Okay, that's the way, correct.
RH incompatibility, sir. RH incompatibility and infections.
Sure.
Actually, RH incompatibility will start at first day of life, sir.
అసలు బ్లడ్ గ్రూప్ ఏమి ఉండే సార్ చెప్పిన
బ్యాక్గ్రౌండ్ లేదు కదా, నెగటివ్
ఆర్హెచ్
పాజిటివ్
లేవు కదా అట్లా.
సో అది తీసేస్తారు కదా. మదర్ ఈస్ నాట్ నెగటివ్, బేబీ ఇస్ నాట్. సో దట్స్ background scenario is not there for it to happen, so you would like to
remove it. Mother O కాకపోతే అది కూడా తీసేయాలి, ABO కూడా.
ABO incompatibility.
So Lakshman Kumar sir is saying please shortlist 2 or 3 diseases. So what are the 3-4 things which you would like to prioritize?
Okay, straight away, can you think of hypothyroidism? Yes or no? You tell me some points regarding that.
Yes, sir. And prolonged jaundice. Prolonged jaundice ఉండొచ్చు సార్.
What are the
అంటే do you think only jaundice at the child?
Then why didn't you give Dubin Johnson also? What was the reason you did not include Dubin Johnson?
Dubin Johnson usually conjugated fraction will be
okay, very good. Very good. Then you already know. No, right. Type
Dubin Johnson means dark colored liver, dark, deeper D. Okay. Hypothyroidism, you should see clinically, Vinod. Clinically, you should tell, not only just jaundice. Clinical criteria, how you diagnose hypothyroidism.
So, clinical examination, what are the fontanelles you would like to see? How, whether the child had any feeding difficulties.
Just appearance.
So, things like
wide open anterofontanelle and opened postfontanelle.
So, that itself gives you the clue.
Clue for the hypothyroidism.
What are the other presentations?
Yeah.
Appearance, activity.
Child will be lethargic and dull active.
What are bowel habits?
Constipation will be there, sir.
Okay. Even unnaya leva, or they are not present or absent?
Dysmorphic features. Dysmorphic
faces will be there, sir.
So you did not say a single word about the, you are kept as number 1, but you didn't say anything about
nothing is there about hypothyroidism.
So remember, Vinod, when you have a high probability, lead the examiner towards your diagnosis.
Your diagnosis. Always you should drag the examiners. You should not be trapped by the examiners. Always you should drag the examiner. Don't be trapped by examiners. Okay.
Carry on.
Okay.
So investigations were done. Right?
Okay.
Afterwards, I'm explaining every DD, man, how I removed it, whether clinically or after investigations.
Okay.
So hemogram, HP was 13.3 gram per deciliter, RPC was 4.47 millions, PC was 40.2, WBC count was 10,100. platelet count was 3,86,000. Characteristic count was 1.7. Liver function for TSB we sent liver function test. Total serum bilirubin was 27.5. Indirect bilirubin was 26.5, and direct bilirubin was 1. And ALT was 28, AST 43, ALP 248, and GGT 61. Total serum proteins were 5.5. Serum albumin was 4, and serum globulin was 1.5. Mother's blood group was B positive. Baby's was O positive. It was non-consanguineous marriage.
Day 1 means on 26th day or 27th day.
26th
Your day
day,
1, yeah, I don't know. 27.5 on day 1 at MGM.
Yes,
That is 26th day, 27th day.
yes.
Of life.
29th day, sir.
Okay.
Day 1 of admission.
Carry on. So this is on 27th, 28th day.
Sir, 29th day of life, sir. That is day 1 of
Okay,
admission.
carry. Right, carry on.
Direct home test was negative, and ultrasound abdomen was normal. HbA1c was negative, and complete urine picture was normal. Thyroid profile was normal, and septic screen was negative.
See here. Okay.
This was serial.
When such a level of baby was dull,
No, ma'am, it was active.
because such a high level of serum bilirubin with indirect component in the absence of your retic count is 1.77, I think. Correct?
Yes.
Retic count is not elevated. Retic count is not elevated with unconjugated hyperbilirubinemia.
And Coombs test negative.
Negative. So would like to think of non-hemolytic unconjugated hyperbilirubinemia.
Yes.
So in such cases, though there is no history of consanguinity, I would like to put in the neonatal period presentation with such high Crigler-Najjar type 1, which will often go up to the level of kernicterus in the neonatal period. Maybe that differential has to be kept in mind. Type 1. Yes, sir? Type 1 will often present in neonatal period with such high levels of unconjugated hyperbilirubinemia, often lead to kernicterus. That should be one. Yeah, carry on.
Even Gilbert's.
Hypothyroidism. How I removed it?
Lab findings, it would not suggest of hypothyroidism.
Hypothyroidism.
But how is the posterior fontanelle is closed? Posterior fontanelle?
Ma'am, closed, ma'am.
Closed. But feeding difficulty, no inactivity, poor feeding, no coarse features. Okay. No history of constipation. Not suggestive. How about, have you checked the X-ray? Have you taken any skeletal X-ray?
Bone age? Bone
No,
age, X-ray for bone age.
Okay.
Any
Proceed.
features of Downs?
No, sir. No Downs features, sir. No coarse features are there, sir. No velocity, yes, sir. Breast milk jaundice. This condition may be manifest as persistent of physiological jaundice, which may appear for first time at end of the first week, sir. It is maximum in intensity between 10 to 14 days. But hyperbilirubinemia is never severe enough to need exchange blood transfusion. Clinically, baby was well, active, sucking was good, accepting feeds, urinary output bowel was normal. So breast milk jaundice, clinically it may be not, sir.
Okay.
ABO incompatibility and RH incompatibility. Baby's blood group was B positive and mother's blood group was O positive. And laboratory findings, peripheral blood smear was normocytic and normochromic. Direct home test was negative, and retic count was 1.77, which excludes this both incompatibilities.
Okay.
Because of no severe anemia. Red cell enzyme deficiencies. P6PD deficiency, most common genetic disorder in India, and X-linked recessive inheritance. but clinically no pallor and anemia was not there, and normal red count was there. We didn't send G6PD analysis.
Okay.
And lucid Driscoll syndrome is also known as the transient familial neonatal hyperbilirubinemia. Severe unconjugated hyperbilirubinemia may be occur during first 4 days, first 3 days of life due to
This is ruled out.
rule out, ma'am. And Gilbert syndrome. This will be the cause, ma'am. Characterized by intermittent jaundice in the absence of hemolysis or underlying liver disease. The hyperbilirubinemia is mild and may be precipitated by dehydration, fasting, stress, intermittent illness. In neonate, it may cause significant hyperbilirubinemia. And
But not to the extent of 26 and all. See, almost 26 in a 2.5 kg baby is almost falls into. You had shown that chart, no?
Yes, ma'am.
Okay, carry. అక్కడ ఎక్స్చేంజ్ ట్రాన్స్మిషన్ లెవెల్లో పడిందా?
Yes, ma'am. Exchange transmission level on 27 ఉండే మ్యామ్. 27 అంటే exchange transmission level వచ్చింది.
Okay.
And Crigler nature, it is an autosomal recessive disorder characterized by non-hemolytic unconjugated hyperbilirubinemia due to the congenital deficiency of glucuronide transferase, UGTI. Type 1, type 2 are there, ma'am. Type 1 is very severe condition and autosomal recessive inheritance. Usually in day 1 of life, they are present with more than 20 milligram per deciliter. And diagnosis can be made by microSC of UGT activity. And treatment may require exchange transfusion followed by the phototherapy. And ultimate treatment was liver transplantation. Whereas Crigler nature type 2, autosomal recessive or autosomal dominant type of inheritance was seen, caused by single base pair mutation leading to decreased enzyme activity.
That's all true. How are you differentiating one from the other is the point which you should tell us. Yeah, next.
Particularly Crigler-Najjar type 1 and Gilbert.
Type 2, sir. Type 2 or Gilbert.
Next. You managed with phototherapy and phenobarbital. Yeah.
Phototherapy and phenobarbital content. This was the genomic sequencing because we all excluded differential diagnosis. There was no hypothyroidism, there was no AV1 compatibility, there is no RH incompatibility. The breastfeeding was good, breastfeeding was very good, and Gilbert, it may be Gilbert or Crigler-Najjar syndrome.
How you confirm which one, Gilbert or Crigler-Najjar?
By gene sequencing, sir. And usually Gilbert will precipitate by stress conditions, and usually does not significant jaundice will be not there, sir. But yes, up to exchange transfusion.
Okay.
Gilbert's is a milder disease which comes and lasts for few days and goes off. It will not cause much harm to the baby. And also it will be, as you had mentioned, it is stress or dehydration and all. But to the extent of presenting such high levels is unlikely for Gilbert's. And the response to phenobarbital is often seen in Crigler-Najjar type 2 because there is a partial deficiency. Is it here? Exon 1, exon 3. Sriram Reddy sir, your comments.
Very good, madam. No, for the postgraduates, just I want to say a few things. Only thing is, instead of discussing about Crigler-Najjar and Gilbert's, just how to proceed.
Algorithm, how to approach the child.
That is very simple. Very simple. Just whenever you find exaggerated physiological jaundice, better go first to do the Coombs test. If the Coombs test is positive, that the algorithm what you follow should be adopted by every postgraduate. It should know about it. Then followed by a reticulocyte count. Then you come down to the hemoglobin levels and other things and the morphology of the RBC. Till then, everybody should do practice and everybody should learn. So whether it's direct or indirect. If the indirect is exaggerated or prolonged for a long period, do the Coombs test. If the Coombs test is positive, then go for the hemoglobin levels. Then come to the reticulocyte count. Then go to the differential diagnosis of rare possibilities. That's the way what I want to tell to the postgraduates.
Hello, one point, madam. 1 point.
Yeah, please go ahead.
1 point. In this case, any case of jaundice on 25th day, we don't want to buy time, so we have to rush to diagnose whether it is conjugated or unconjugated. That is the priority, madam, because we have to diagnose conjugated jaundice as early as possible. Okay, and in this case, it was obvious that it is a unconjugated hyperbilirubinemia, and my child is also had a jaundice, and the child was treated for phototherapy and subsided. And again, they came for increased jaundice. Maybe some jaundice may be present, maybe they may have overlooked it, madam. So again, when the jaundice has deepened, they came to us. So then we tried to rule out all the possible causes. And we had initially in mind of this Kriegler because the 26-day life and baby child was responding nicely to phototherapy. And again, when we stopped phototherapy, again, the bilirubin was increasing. So we sent for exomic sequence. And it turned out to be Kriegler type 2, madam, this child.
Yeah.
So for the clinical importance, we try to present this case.
Yeah. Nice case. So for the point for all the postgraduates, go as per the algorithm. So you will not miss and the number of investigations also we will be able to keep to a minimum. And earlier we'll be able to pick it up when we go the algorithmic approach. And Dr. Gopal Singh, sir. Your comments, Dr. Vijay, sir?
Yes, definitely.
We have one more short case. We'll try to finish it off very briefly. Dr.
Definitely.
Shweta, another 10 minutes, please give us 10 minutes. Shweta.
Okay. Proceed. Who has to give it to you? You are the controlling authority.
Let's sir,
Nobody is
DIAP platform, sir. DIAP
Okay.
valuable, sir.
Okay.
Yeah. Maybe
Go ahead. Go ahead.
no
madam.
job.
Vinod, right. There was a lot of information when the child has come to you. And then while presenting, right, it's a worked up well, you had the advantage of the previous past history. And when you present it to the world, probably this was not the way to say that 26, the jaundice was, you have seen it on 26th day. And when we present to the professional world, we will present whatever we have with us. So presenting on 26th day, that the jaundice we have seen on 26th day, but was there on 3rd day. This is a serious objection a professional community would tell us. Okay. Well worked up, right. When the child comes back, what are the chances that this child comes back at 3 months with jaundice again, 6 months with jaundice again? What would be your follow-up? What investigations you want to do? This baby is 2 months now, 1.5 months now. What are the chances that this baby comes again with jaundice at 3 months, 4 months, 5 months? And what are the other tests you want to do? Minimum tests you want to do?
First, I will check about where it is unconjugated jaundice or conjugated jaundice, sir.
No, it is confirmed now. You have come to the gene level, and the conjugated is unconjugated gone. Conjugated is gone.
So here, what sir wants you to know is asking is, how would you follow up this child? How do you follow up this child? Is what. So now you have started the child on phenobarbital and the serum bilirubin levels have come down as per the your slides. So how would you like to continue phenobarbital, or would you like to and when you want the child to come back to follow? Dr. Surinder, sir.
So we asked the child to follow up because the child like to increase jaundice and may require phototherapy also, intermittent phototherapy for more years, I think. And as the child grows, he may need phototherapy in the night time also, because not to interfere with routine activity. So we ask the child to follow up, madam.
Okay. Yeah, sir.
Vinod, what are the chances? What is the effect of this jaundice on CNS?
No, if proper treatment was not taken, sir, then there may be acute intrahepatic vulnerability, sir. But after neonatal period, blood-brain barriers will be.
What test you want to do, boss? What minimum test you want to do? Shall we discuss tomorrow? It's okay.
Yeah.
Okay,
Tomorrow
We'll
we'll
go
discuss.
move on.
Tomorrow
Thank
we'll discuss. Right. Nice, good presentation.
Yeah.
Right.
Very a good case for discussion, and thank you, Dr. Surender sir, and Dr. Anil. If you are there, would you like to say? Anil, Assistant Professor Pediatrics from Warangal, MGM College. Dr. Anil, he was guiding.
Madam,
Yeah.
good evening.
Yeah. Good evening, Anil. Cheppandi.
It is a case of prolonged unconjugated jaundice, non-hemolytic jaundice. So we presented it.
Yeah. Thank you. Thank you. Dr. Saujanya, can you start sharing your screen? So,
yes, ma'am.
Be brief. Don't tell huge negative history. Come to the point. Yeah. And we have
yes,
Dr. Saujanya presenting from Nilafar Hospital, postgraduate, second year postgraduate. Similar, I mean, it is also a case of jaundice. And I would like to thank Dr. Surender, and we appreciate the very bringing up a nice case for discussion. Dr. Vinod and Dr. Anil. Thank you very much. Yeah. Please go ahead. Start.
Good evening, respected faculty. Yes, ma'am. This is a 10-year-old female child, Sanvi, resident of Hyderabad, was brought to Nilafar Hospital by her parents. The chief complaints of fever for 5 days, vomitings for 5 days, loose stools for 5 days, and yellowish discoloration of eyes since 4 days. The fever was of low grade, continuous type, not associated with chills and rigors, not associated with rash, no diurnal variation, and the child was active in between the febrile episodes. Vomitings were there for 5 days, which were around 4 to 5 episodes per day containing food particles. Loose stools were also there for 5 days, which were 8 to 10 episodes per day, watery in consistency. Yellowish discoloration of eyes started on day 2 of illness, which was sudden in onset, non-progressive in nature, associated with yellowish discoloration of urine. There was no history of itching, pale stools, or bleeding manifestations, drowsiness, or easy fatigability. There was no history of abdominal, negative histories, no history of abdominal pain or abdominal distension, no history of decreased appetite or weight, no history of decreased urine output, no history of recent intake of outside food, no history of any drug intakes, no history of GI bleeds or TB contact. Past history, the child had similar complaints in the past 3 episodes, which were at 3 years, 7 years, and 9 years of age. In every episode, there was fever followed by aggression, which lasted for 2 to 3 days. And there was spontaneous resolution of jaundice within 5 days of fever. The child had received paracetamol and oral antibiotics for these febrile episodes, and there was no history of blood transfusions in the past. Birth history was not significant. Natal history is normal. Postnatal history is not significant. Family history, father also had similar complaints, which were about 5 to 7 episodes till now. And he also had fever followed by jaundice, which lasted for 3 to 5 days. The child is first in birth order of a non-consanguineous marriage. Developmentally normal child, immunized according to the age. And nutritionally, there is deficit of 240 calories and protein deficit of 2 grams. Child belongs to lower middle class according to modified Kupuswamy scale. Summary of history: a 10-year-old female child, first in birth order, born out of non-consanguineous marriage, brought with complaints of fever for 5 days, vomitings for 5 days, loose stools for 5 days, and yellowish discoloration of eyes since 4 days. History of similar complaints were present in the past and similar complaints in the father. At the end of history, my provisional diagnosis could be because of fever followed by loose stools and vomitings, and ICTRES was there, but with a lot of acute viral hepatitis and leptospirosis. But since there is recurrence of symptoms and family history, the family history was there congenital, any causes of hemolysis like increased production or decreased uptake are encouraged. Should I move for examination?
Yeah.
General physical exam, child is comfortable sitting on the bed, conscious, cooperative, oriented, and icterus was present, moves, pallor, cyanosis, clubbing, or lymphadenopathy. Vitals, the child pulse rate is normal, heart rate, respiratory rate is 20, BP was 100/70, temperature and SpO2 are normal. Anthropometry, the child belongs to 25th percentile of weight and height, and BMI is also lying in 25th percentile. Child is SMR, belongs to SMR stage 1. On head-to-toe examination, head-to-toe examination is normal except for icterus and oral mucosa was tried.
అయిపోయింది కొంచెం లాస్ట్ లో ఉంది అయిపోతుంది ఫస్ట్ ఒక 5 minutes వచ్చేసి
Since
అయిపోతుంది
it is,
Yeah, continue.
yes,
Next
since it
slide.
is fever followed by loose stools and vomitings and icterus, I would like to go with GI examination. GIT, oral mucosa is normal, and on inspection, GIT was normal. Palpation and percussion and auscultation of GIT also found to be normal. Other system examination also was normal. Summary. A 10-year female child with the complaints of fever, vomitings, loose stools, and yellowish discoloration. And the child had similar complaints in the past, and the complaints are also there in the father. On examination, icterus was present, and there was no organomegaly. So, these are the DDs.
Yeah, Dr. Gopal Singh. Sir, Gopal Singh sir, unnara?
Yes, madam.
Yeah, take it forward, sir.
Okay. Nice presentation, madam. It's a very selective cases. So, first of all, we'll congratulate the team and the faculty, those who are guided them. And the same, maybe we have to think of the cases like there is a family history in this child. Father is also having similar history. And Vijay Kumar sir also putting the same question maybe. What is the management next? And this child is around 10 years.
Yes, sir.
Okay.
This is a 10-year-old child, sir. Possibly, Gilbert and Grignell as a two can present at this age, sir.
with 4 episodes so far.
Yes.
Yes, sir. But Crigler-Najjar 2 usually presents with more amount of jaundice than Gilbert syndrome, and it responds to phenobarbital, sir. And Gilbert syndrome is usually, as discussed, it will be triggered by stress, dehydration, or any kind of infection, sir. Hemolytic anemias can also present with this, can present like this, but there is no icterus, there is no splenomegaly, sir. And since it is a female child, G6PD deficiency is quite unlikely, sir. So we thought of Gilbert and Crigler-Najjar. In follow-up of these babies, these children do not need any particular treatment, sir. We will just tell them to avoid the stress and dehydration, sir. And in any kind of infection, they can icterus can be there, sir. And treatment with irinotecan can precipitate Gilbert icterus in Gilbert syndrome, sir. So in Gilbert syndrome, follow-up, you should ask them to avoid irinotecan therapy if they are subject to cancer in future.
Yeah, go ahead.
Investigations, complete hemogram is normal, retic count is only 1%, and TSB was 5.1 at the time of admission, and 2 days later TSB came down to 1.1 with the major indirect bilirubin. Other viral markers, tickling, ultrasound abdomen, CU were normal. DCT was negative, and other RFTs and FTs are not significant. Also, we have done UGT1A1 gene polymorphism, which showed 7/7 alleles at 7/7 TL 28 allele, which is suggestive of Gilbert syndrome.
ఒక్క క్వశ్చన్
చెప్పండి సార్.
డాక్టర్ పేరేంటమ్మా?
సౌజన్య.
Well elicited history. You have presented your provisional diagnosis well, and for a given provisional diagnosis, you have planned your investigations. Right? You have given a battery of investigations. Given chance now, which investigations you don't want to do at all? which gave zero information to you, rather. Given chance, which investigations you don't want to do?
LDH is not needed, sir.
Ultrasound abdomen?
Ultrasound abdomen, yes, sir. Since it is indirect bilirubin, ultrasound is also not required, sir. But
Excellent.
even vomitings, we thought of hepatitis also, so we have done ultrasound.
Ultrasound doesn't tell about hepatitis. Huh?
Yes,
No, ultrasound, you said you have identified well, right? Carry on.
So in which type of hemolytic anemia you would like to go for an ultrasound rather?
In his hereditary spherocytosis, we can look for gallstones.
Huh.
No, hereditary hemophilia, peripheral smear is enough. Huh? Your RDW helps you, not ultrasound.
Gallstones can be there.
Then don't complicate. What is pre-test probability? What is pre-test probability? Let's not go into that. This is a very good case. I'll stop at this point.
Yeah.
Before.
Yeah. So here, most of the discussion had happened in the previous case. So that's why we tried to run through the slides. Here, the history is very typical. Non-hemolytic unconjugated hyperbilirubinemia. And with the family history where the father had episodes, even the child had multiple episodes, which never required admission or any blood transfusion. If there is anemia, splenomegaly with the unconjugated hyperbilirubinemia, it is a triad of the hemolytic anemia, which goes in the algorithm of hemolytic anemia. But here, because there is no transfusions history or no history of clinically also significant anemia. With the family history, you will think of non-hemolytic unconjugated hyperbilirubinemia, of which you will come down to the various unconjugated hyperbilirubinemia as discussed by Vinod, Dr. Vinod. So here type 2 Crigler-Najjar, which is milder form, and Gilbert's come into the picture. And among them, Gilbert is much milder than the Crigler-Najjar type 2. Because of the age of onset and the type of presentation where it is a self-limiting. Gilbert's is usually self-limiting where the treatment, it is spontaneously recovers. Earlier, they used to, phenobarbital was recommended, but now it is a conservative management, not much, no significant, no treatment is.
Right, but as you said, Gilbert means G. G means good. The problem is entry into the liver cell. Whereas Crigler-Najjar within the cell, problem is within the cell. And Dubin-Johnson outside boyedaniki cell exit dagara obstruction will be there, Dubin-Johnson. So darkness will be there. So GCD is the mnemonic, remember, for this all enzyme defects. Gilbert entry problem. Crigler-Najjar transformation conjugation problem, Dubin-Johnson exit problem. This is and as you said, Gilbert-Najjar G for G, good. Always prognosis is good.
So, what is the prognosis and complications? Dr. Lakshman Kumar sir is asking.
Prognosis is good, ma'am, and there will be no big complications except for mild increase of fitness in cases of dehydration or any kind of stress. But the only thing is we should avoid irinotecan therapy in Gilbert patients because this drug is metabolized by the enzyme UGT1A. We should avoid the drug.
The one word in hepatitis is thought of vomiting. Is it vomiting or nausea if you think of hepatitis?
Nausea will be more, sir.
Nausea
will be more, sir.
How you differentiate is nausea and vomiting? Clinically,
vomiting is there. Vomiting is forceful expulsion of the food material.
History, what do you ask? History, what do you ask exactly to differentiate? Nausea means they don't want to eat. Salivation, they don't want to eat nausea. Vomiting fellows, they may vomit and eat again. Okay, proceed.
Yeah. So, we are at the end of today's session and Dr. Suresh sir has joined in. Sir, over to you.
Yeah, thank you, Dr. Nirmala. And I thank long session and very good cases. So I thank the presenting.
Stop sharing, Saujanya.
I thank the presenting people, PGs, assistant professors, and Dr. Vijay Kumar, Dr. Ramya Madam, Dr. Nirmala for bringing excellent cases today. And I thank chairpersons, our senior professor, Dr. Venkat Ramnath Reddy sir, Dr. Sriram Reddy Garu, and Dr. Gopal Singh for chairing the session. So the PG clinics of PATS have come a long way. Every time we are trying to experiment and not to repeat the same thing again and again. So we went with long cases. Now we went with short cases. So whatever is there in exam, we are trying to give a mix and match so that all postgraduates will be useful. And this time we try to include more people from Karimnagar, Warangal. The clinical material is there throughout the state, and excellent teachers are there. We want to give this as a forum to explore potential of PGs and to show the cases on a state level. So thank you very much, and I thank President Dr. Arakal Bhaskar and Secretary Pawan Kumar for the constant support and encouragement. And I thank all the senior faculty, all the senior members who have been giving a helping hand by providing cases and suggestions to improve this program. Over to you, Pawan.
Okay, very
Dr.
good.
Chaitanya?
Very good, Suresh. This is the best way of teaching. Teaching with only clinical exam presentation is the best way for learning, not just didactic lectures. This should be, as you rightly said, after long case, short cases also, in a short time we can learn more things. So very good. Kudos to Suresh. Go ahead.
So my Dr. Chaitanya Jyoti, assistant professor pediatrics from
good evening.
Your
comments.
In Reglan as a type 2, enzyme activity will be 10% preserved. In Gilbert, it will be 30%. And main thing is like stressors should be avoided in this Gilbert child. And the parents should be, assurance should be given to the parents. Yeah, thank you.
Yeah, regarding the follow-up and complications, what would you tell the parents? How will you counsel the parents?
Wherever you got jaundice previously, what was the problem you thought of? Such problems should not be repeated. They should ask them. See, actually, to avoid stress and counseling means you should questioning the patient and the patient answer also for his questions, because they know the better what was the problem in the previous, what was the stress due to. So same thing should be avoided. That is the way you should tell.
The stressors which can be avoided should be avoided, like excessive physical exercise, strenuous exercise, dehydration, any infection, immediate treatment of that should be done.
Usually the same triggers will be the repeating. That's why they should know parents very clearly.
Thank you, Dr. Chaitanya, for bringing up this, presenting this. Thank you.
So
over to Pat.
Bhaskar sir.
Dr. Bhaskar sir.
Bhaskar sir.
Very good, lively discussion so far. And I congratulate all the 3 PGs for facing such a rigorous, grilling questioning by all 3 learned professors. But all PGs got very good clinical tips, sir. And the very idea of conducting these PG clinics is to orient the PGs to face the examinations, not to tell the final diagnosis. So, and basics is more important than the final diagnosis.
And to drag the examiner towards them, and to try to drag the examiner towards them, not to be dragged by the examiner, or trapped by the examiner. Yes.
That is the most important point, sir. And for all exam going PG, you should be one part of chairperson, sir, so that you can give more and more practical tips. And I also advise all PGs to be familiar with all protocols and algorithms when approaching a case, and also should be very familiar and authenticate with the basics of a clinical examination of a child in the examination. And the examiners will see how you are approaching child, not your final diagnosis.
And that approach should be with confidence. Suppose
Yes,
though you know everything, if you are not telling properly, examiner will think that you are not confident. So you know something also, but be confident, then examiner will think, oh, you know better.
Yes, and I congratulate mentors, Professor Ramya Madam, Professor Surendra Sir, and also Professor from Nilofar Hospitals. And also appreciate the presence of all seniors, Dr. Ranganath, Dr. Himabindu Madam, Lakshman Kumar sir, and many. They are very interestingly and actively participating like a postgraduate students. Thank you,
Because
sir.
they are all examiners. They should learn first.
Thank you, sir. Thank you.
Thank you. Madam, can you have a half-minute comment from you, Madam? Himabindu Madam?
Sir, actually, really, I was very much, I wanted to always, listen to Nirupa and all of you. And I was very excited today. I made it a point, though I'm traveling, that I should join. And I'm very, very happy that being a and this platform, the PG clinics have started in under your leadership. And it is really one of its very high standard discussions today. And it's like many of the states are doing, but we are no less. And we have so many good teachers amongst us. And very nice to hear Dr. Ramanasamiti sir of a long time. And Suresh Surapaneni and each one of them, including Dr. Vijay Kumar sir, Dr. Sriram Reddy Garu, and
Dr. Gopal. Yes.
Yeah. Very nice initiative by our state, sir.
Thank you, madam, for your inspiring message. Thank you, madam.
Congratulations, sir.
Thank you.
Thank you.
Thank you, Dr. Nirmala madam and Dr. Suresh. Can we say good night? Thank you.
Good night, sir.
Okay.
Thank you very much.
Bye-bye. Bye-bye.
Thank you, sir.
Good night,
Good night.
sir. Thank you all.
Well, actually, sir, I think this way, our postgraduates also will, really benefit that this IAP is a good platform for learning and academics.
And not only that, the membership also will increase because of this. Membership. I always think of membership now.
We also acknowledge the presence
Actually,
of
there should be a
Dr.
rule.
Ranganath,
Those who are
sir.
presenting
Thank
cases
you.
should be a member. Those who are presenting, Dr. Nirmala,
Sir.
Those who are presenting the cases, postgrads also should be member of the IAP.
Every vote counts.
That's why
Yes, sir.
they should also member of IAP. All students also those are.
They're all AL, sir. They're all associate lives.
Okay, right. You made a rule like that. That's better way of.
Sir, there is a rule for paper
mandatory
presentation.
sir.
Yes. Okay, that's better.
Rule for paper presentation.
Yes. Always think of ourselves also.
Okay, sir. Thank you, sir.
Election season, sir. Every vote counts.
Good night.
Yes.
Good night.
Good night,
Good night, sir.
Good night.
Good night, madam. Good night. Wonderful
Good
job.
night, sir.
Good night. Suresh, bye, bhaiya. Suresh,
Bye, bye. Bye, Lakshman.
Bye, sir.
Bye.
Good night.
Good night.
Bye-bye.
Thank you, sir. Thank you.
Madam.